Good morning. This is Dr. Cindy Herndon, and I'm going to be presenting Chapter 19, Nursing Care During Obstetric Procedures. And here are your learning objectives. Identify clinical situations in which specific obstetric procedures are appropriate. Explain risk, precautions, and contraindications for each procedure. Identify nursing considerations for each procedure. Identify methods to provide effective emotional support to the woman having an obstetric procedure. Apply the nursing process to plan care for the woman having a cesarean birth. And the first thing we need to look at is the amniotomy. And an amniotomy is often performed in conjunction with the induction or stimulation of labor or to permit internal electronic fetal monitoring. And this is a common procedure, but it implies a commitment to delivery. So once you break the waters or break the membranes, breach the membranes, you need to go ahead and plan on delivery of the baby for several reasons. It is usually seen as a harmless procedure, but the nurse must observe for three major associated risks, and that is prolapse of the umbilical cord and compression of the umbilical cord, infections such as chorioamnionitis or an infection of the amniotic sac, and birth within 24 hours is desirable after the rupture of membranes in term pregnancies. Abruptio placentae is a premature separation of a normally implanted placenta, and this may occur if the uterus is distended when the membranes rupture. The risk is greater if there is excessive amniotic fluid in the uterus called hydramnios. And there's a figure 19.1 in your textbook speaks more to this, and I would definitely recommend that you look at that. And this is just a picture of the fetus in the amniotic sac, or in the sac in the uterus, and with the amniotic fluid surrounding and cushioning the fetus. On the right, you have a picture of the hook that is used to rupture the membranes, and then mechanically, purposefully to begin labor. And then on the left, you have a diagram of the or sketch of the membranes, the hook, and the fetus. And this just shows highlights and features the chorionic villi, and this is where the infection could occur. One area that is high risk for infection if once the membranes are ruptured, and that we worry about infection occurring. So you have a picture here of the fetus in the sac and the placenta implantation, and then the chorionic villi is featured in the box. Induction and augmentation of labor use artificial methods to simulate uterine contraction. Techniques and nursing care are similar for both induction and augmentation. Indications: the induction of labor or artificial initiation of labor is considered when ending the pregnancy, and this benefits the woman or fetus, and when labor and vaginal birth are considered safe. Labor is not induced if the fetus must be delivered more quickly than the process permits. A cesarean birth would be performed instead if that is the case. Examples of specific conditions that are indications for induction include fetal compromise, including intrauterine growth restriction, and Rh incompatibility, spontaneous rupture of membranes near term, post-term pregnancy, chorioamnionitis, hypertension associated with pregnancy, maternal medical conditions, and fetal death. And this is the Bishop scoring system, and this system is used to estimate how easily a woman's labor can be induced. Higher scores are associated with a greater likelihood of successful induction because her cervix has undergone pre-labor changes, often called ripening. A woman who has given birth before usually has a successful induction when her Bishop score is 5 or higher. Delivery in a woman who is having her first baby is most successfully induced if her score is 7 or higher. The birth attendant evaluates whether labor and birth are safe for the woman or fetus, then continuing the pregnancy. Labor is not induced if term gestation and/or fetal lung maturity are not established unless there is a compelling reason. Induction is more likely to be successful at term because pre-labor cervical changes favor dilation. The Bishop scoring system uses 5 factors to estimate cervical readiness for labor, and those factors include cervical dilation, effacement, consistency, position, and fetal station. The Bishop score remains popular because of its ability to predict probable success of induction. The likelihood of vaginal birth is similar to that of spontaneous labor if the score is greater than 8. Any contraindication to labor and vaginal birth is a contraindication to induction or augmentation of labor. These conditions may include placenta previa, where the implantation is in the lower uterus, and this can result in hemorrhage during labor. Vasa previa, where the fetal umbilical cord vessels branch over the amniotic sac rather than inserting into the placenta. Fetal hemorrhage is a possibility if the membranes rupture. Abnormal presentation, for which a vaginal birth is often hazardous. Umbilical cord prolapse, in which immediate birth by C-section is indicated. Some uterine surgery, such as a classic cesarean and extensive surgery for uterine fibroids, may be a contraindication as well. Other maternal or fetal conditions are not contraindications to induction but require individual evaluations, such as one or more previous low transverse cesarean births, a breech presentation, maternal heart disease, severe maternal hypertension, uterine overdistension such as with multiple pregnancies, and especially triplets or higher. Hydramnios, cephalopelvic disproportion, and a non-reassuring fetal heart rate pattern. Surgical, medical, or mechanical methods can be used for labor induction. Amniotomy is a surgical method of induction and augmentation because rupturing membrane stimulates uterine contractions if the cervix is favorable. If it is soft, some dilation is there and/or effacement is happening. Medical methods for induction or augmentation involve the use of drugs such as prostaglandins, intravenous oxytocin or pitocin, or both to stimulate contractions. Mechanical methods of induction use a variety of intracervical inserts to gradually stretch and soften the cervix. Cervical ripening are procedures to ripen the cervix, making it more likely to dilate with forces of labor and are a common adjunct to induction. Medical methods utilize preparations containing prostaglandins, and these can be used to facilitate the cervical ripening, and this can be given as an intravaginal or intracervical gel or a time-release vaginal insert. And this would be administered in a setting in which fetal monitoring and emergency care, including immediate cesarean birth, are readily available. Prostaglandins should be given cautiously to women who have asthma, glaucoma, ischemic heart disease, pulmonary, hepatic, or renal disease. Tachysystole that can reduce placental blood flow and fetal oxygen exchange is a major adverse reaction to prostaglandin administration. And the fetal heart rate and uterine activity should be monitored prior to prostaglandin administration to assess for a baseline, and then at least every 30 minutes afterward for reassuring fetal heart rate patterns of excessive contractions. Misoprostol or Cystatec is popular for pre-induction cervical ripening and labor induction because of its low cost, stability, and ease of use. Misoprostol is a synthetic prostaglandin tablet that is used for prevention of gastric ulcers. Its use for cervical ripening or labor induction remains an off-label use. Mechanical methods. Any of several techniques such as transcervical catheter placement of a balloon-tipped Foley catheter in the cervix with possible saline infusion through the catheter into the space between the internal os and intact membranes can be used. And placement of hydrophilic or moisture-attracting inserts into the cervical canal where they absorb water and expand, gradually dilating the cervix, can be used. And examples are Dilapen S and Lamisil, Laminera Tense, and this is sterile cone-shaped preparations of dried seaweed. And more than one can be placed in the vagina to absorb water and expand. Oxytocin administration is also used. Oxytocin is a powerful drug. Several precautions reduce the chance of adverse reactions in the mother and the fetus. And on page 382, read and know this material. Also figure 19.3 in your text. In addition to the basic intrapartum care, the nurse observes the woman and the fetus for complications and takes corrective actions of abnormalities if abnormalities are noted. The nurse has a great responsibility when administering oxytocin or other uterine stimulants. The nurse must maintain safeguards to both the mother and the fetus and recognize when to start, when to change, or when to stop oxytocin infusion, and also when to notify the physician. Facility policy is always in place for oxytocin administration. The nurse observes the fetal response to uterine contractions, which may become hypertonic, which may reduce placental blood flow and reduce its exchange of fetal oxygen and waste products. Before induction or augmentation of labor, the nurse determines whether the fetal heart rate and the patterns are reassuring. The fetal heart rate is charted in the labor record every 15 to 30 minutes during the first stage of labor and every 5 to 15 minutes during the second stage of labor. The nurse remains alert for fetal heart rate patterns that suggest reduced placental exchange secondary to contractions that are too strong or too long or do not relax at least 30 seconds. And this is tachystole. And the fetal heart rate that is concerning includes bradycardia, or less than 110 beats per minute at term, and tachycardia, greater than 160 beats per minute at term, and then late decels. And we learned that earlier in the earlier chapters, where slowing heart rates, fetal heart rates, after the peak of contraction occur, and there is decreased fetal heart rate variability, and is not explained by fetal sleep or medications. So these are the nursing considerations. There is more in your text, and please be you are responsible for knowing the material in your text. And these are signs of tachystole, and they are contractions lasting longer than 90 to 120 seconds, and contractions occurring less than 2 minutes apart or less than 30 seconds between contractions. And uterine resting tone is above 20 millimeters of mercury, or peak pressure higher than 90 millimeters of mercury during the first stage labor. In Montevideo, units greater than 400 are also a sign. The fetal heart rate pattern of late decelerations accompanying hypertonic uterine activity is also an important sign. And these are all listed, and you can read them on page 385. Read more about that and read more into it. It will enhance your ability to care for your patients and to pass NCLEX. And nursing actions for tachysystole include reduce or stop the oxytocin infusion. That is very important. And then increase the rate of the primary non-additive infusion to kind of clear the oxytocin from the lines and from the woman, and keep the laboring woman in the lateral position to prevent cord compression and increase fetal placental infusion. And then give oxygen by snug face mask, 8 to 10 liters per minute. Notify the physician or nurse midwife, and these also are on page 385, all of your nursing actions for this condition, and I would encourage you to read those. Now we'll look at version, and either of two methods may be used to change fetal presentation. You have external version or internal version, and this may allow the woman to deliver a vaginal birth and avoid a cesarean birth. External cephalic version, or ECV, has shown to be successful, and some unsuccessful versions spontaneously change to cephalic presentation before labor begins sometimes. So I guess the baby gets the idea, but malpresentation in twin gestations is usually managed by cesarean birth, but internal version may be used for vaginal birth of the second twin. Contraindications, this is not done if a woman cannot or is unlikely to deliver vaginally, and these reasons include uterine malformations that limit the room available to perform the version. Also, a previous cesarean birth may be a contraindication. Disproportion between fetal size and maternal pelvic size is a contraindication, as well as fetal size 4,000 grams or larger. And also, placenta previa is also a contraindication because of the risk for bleeding and hemorrhage. And this is a diagram of version of different ways that version can be completed. And you see that externally, the hands, a nurse's hands, or maybe a physician, maybe a nurse midwife, they are placed on the fetal head and the buttocks, and they just kind of massage the fetus in the direction with the fetal head in a downward position toward the pelvis. And again, this takes a lot of skill to do, and it has to be performed by a trained practitioner, such as a nurse midwife or a physician, obstetrician. So we may get to see that in clinical. Operative vaginal births are spoken to in figures 19.5, 19.6, and 19.7 in your text. And the provider applies traction to the fetal head in these operative vaginal births, either by using forceps, and these are used less frequently today. Also, vacuum extraction is used 4 times more commonly than the forceps. And I have seen this done, and it is interesting, but it was kind of scary for me. It's very interesting to see, but it's also very interesting to see the fetus afterwards, and it usually causes some imprints on the fetal head, and we'll talk about that in just a minute. And may also be used during a cesarean birth to pull the baby through the incision. And this is the vacuum extractor, and the cup is placed on the baby's head, and then the pressure is pumped. So this is a very interesting procedure. These are the forceps that are used, and again, they are not used as common as they once were. Usually, if these are used, an episiotomy must be performed prior to allow for more space for the instrumentation. And sometimes the baby has marks on the head or the face afterwards, but we'll see pictures of that in just a moment. And these are pictures and diagrams of how the forceps are used, and the fetal head there with the forceps around the baby's head, and then the picture of the forceps inside the vaginal canal, and pulling on the baby's head, and then the baby's picture here with the forceps imprint on the baby's face. And this usually heals quickly, but it is concerning for the mother at the time. And it looks like even there's a bruise on the baby's inner portion of the eyelid. So it can be pretty traumatic to see this. These were used, not the forceps, but the, oh gosh, the vacuum extraction was used on my granddaughter. So she did have a spot on her head. But you know, this is very concerning for the parent, but usually they do go away. And this is the vacuum extractor, and this picture of the baby's head is what's left on the baby's head afterwards. Sometimes it's a hematoma, sometimes it's just a slight bruising, slight indentation, and as I said, these usually go away and there's no harm done after a day or so. This is a temporary swelling left on an infant's head after a suction cap has been used to deliver the baby, and it is not a sign of serious injury and may take as little as 2 hours or as long as 2 weeks to disappear. It is also sometimes called caput succedaneum, and it happens during a vaginal delivery, and the flexible plates contract with a vaginal delivery. The flexible plates are on top of the head to allow overlap to help the baby squeeze through the cervical opening and into the birth canal. And because of either maybe nulliparous women who have never delivered, and the vaginal canal is not as stretchy, and this could kind of happen during that time, but This is from the vacuum, and sometimes the vacuum extractors have to be used in the nulliparous. And with some of the trauma associated things that happen with operative delivery, with the mother, there can be lacerations. There can also be large episiotomies that are needed. Also, hematoma can develop. And with the infant, you have ecchymosis, which is a discoloration of the skin resulting from bleeding underneath the skin caused by bruising. Then you also have lacerations with the infant. You may have lacerations, and you may have abrasions. You may have facial nerve injury and intracranial hemorrhage or subgaleal hematoma. And this is when the head between the skin and the scalp and the skull suffer bruising, and it is bleeding that clots and changes from liquid to partially solid forms, and it just causes a bruising on the head, and it looks pretty bad, but it can go away pretty quickly. And this is a facial nerve injury. It may be temporary. Of course, this is a seventh cranial nerve that is injured. Most children do achieve complete or near complete recovery of the facial nerve injury. If paralysis does not resolve, it may affect the child's future speech, expressions of emotion, and mastication or eating their food. But as I said, most of these resolve and are temporary. So this is just a picture of that happening to this sweet baby. Episiotomy. An episiotomy is an incision of the perineum just before birth, and it was once routine for vaginal birth, and the presumed maternal benefits were reducing pain, perineal tearing, and later pelvic relaxation. But these have not proven to be true, and so episiotomies are not routine any longer. The indications for the episiotomy currently are fetal shoulder dystocia, and in instances where forceps or vacuum-assisted birth need to be conducted, where instrumentation is needed, and when the fetus is in occiput posterior position, this may be used. There's a picture on page 391 of two types of episiotomies with advantages and disadvantages listed, but we're going to go over those in just a moment. And so here is your two types of episiotomies, and the midline incision episiotomy is the advantages are minimal blood loss with this procedure. It has a neat healing process with little scarring, and there's less postpartum pain with this one. And then the disadvantages are that it may become an added laceration because it may extend to the median episiotomy with anal sphincter. So it may kind of tear open all the way to the anus, to the anal area, which can be problematic for the future of this woman. So there is limited enlargement of the vaginal opening with this type of episiotomy because the length is limited by the anal sphincter. So all of these are disadvantages, and it seems like the disadvantages outweigh the advantages. I doubt we will see that many of these in your clinical setting, but we'll just have to see. And then for the second type, the mediolateral incision, there are advantages to this incision and disadvantages. The advantages include there's more enlargement of the vaginal opening with this incision, and there are little risk of extending into the anal area, the anal sphincter. And then the disadvantages include that there is more blood loss and more pain in the postpartum period. There's more scarring, and it is there is irregularity in the healing process, and the healed scar looks irregular when healed. There's prolonged dyspareunia, which means painful intercourse. So all of those advantages and disadvantages with these two types of incisions. But again, they are not routine anymore. They're only used in certain circumstances where the physician really needs that extra room to deliver that baby vaginally. And then there's the cesarean birth. The cesarean birth rate in the United States continues to increase. At one time, a cesarean birth was only accounted for 5% of births in the U.S. And now in 2021, the last rate recorded on record was it was 32.1% in the U.S., and that is a big difference. The reason for high rates of cesarean births include the high primary cesarean rate and the repeat rate. So usually, if a woman has a cesarean, she will have a repeat cesarean in future births. Sometimes they consider a vaginal birth after cesarean, which is called a VBAC. But most of the time there are reasons not to do the VBACs, and it might be easier just to plan a cesarean, a second cesarean. And the more cesareans a woman has, of course, you have increased risk of rupture in the uterine muscle. So another reason for increased cesarean birth is increasing obesity among our women in the United States. Vaginal delivery becomes very hard with the more obese a woman is. So the less obesity, the more able a woman is able to vaginally deliver a baby. Also, we have increased induction rate, and with induction, there is a risk for cesarean in induction because of problems with the induction. And so also delayed childbearing. Women are waiting longer to have babies in a lot of circles, and a lot of women are doing that. So the longer a woman delays her childbearing, the more increased risk for cesarean birth. And the preferred uterine incision for cesarean birth is the low transverse. The only time that doctors use a classical incision is with emergency cesareans. And here are your cesarean birth pictures. You have on the top left, incision made at abdomen and anterior one in the uterine. And the baby is removed in the second picture to the left, and then the bottom right, the placenta is removed. And then the bottom right, the incisions in the skin and uterus are closed with sutures. So usually the outer incision is closed with staples. And this shows you the first incision and then continuing incisions. And we'll watch a video of the cesarean birth in just a moment. And then these pictures show the delivery of the head of the baby and the delivery of the body of the baby. And this is actually a very interesting procedure to watch, and I hope that we get opportunities to watch a cesarean birth. And here you have the delivery of the body, and the delivery of the body is complete in the second picture. And then once the baby is completely out, the cleanup and the monitoring, the assessments are being done with the baby and with the mother. And then finally, once the baby is cleaned up, the baby's wrapped up, swaddled, and is presented to the mom, and usually the dad first and then the mom. And so sometimes you have skin to skin with the baby, mother and baby, and the mother gets to breastfeed or place the baby on the breast if she is interested in doing that, and if she's prepared to do that. That's something that's really remarkable to see, because the baby knows exactly what to do. And this just shows your cesarean staples and the scar after it's healed. And so it's not very noticeable usually after it's healed. And it's in an area where the underwear usually come up and cover. So it's just really not that much of a big deal. And now we'll watch a cesarean birth on a video in class. And now we'll talk about the VBAC. And there's a lot to consider with VBAC. Your text has a lot of good information about that, and it's very important that you do read that. You'll need to know that for your test and for NCLEX. And cesarean birth is one of the safest major surgical procedures, although it does pose greater risk for the mother than the vaginal birth. But some women just feel that they have feelings of inadequacy if they have a cesarean birth, as if they didn't do their duty in vaginally delivering the baby. But one good thing about cesarean birth is that it is safe. It is a very safe procedure. Once a cesarean, always a cesarean, always a cesarean is no longer the standard of care now. The low transverse uterine incision reduces the risk of rupture in the future. So these are standard, and so that is a good thing for the VBAC if it's planned. And women should discuss VBAC with their providers to determine if a trial of labor is appropriate. The only downside to that is if the trial does not, if the trial is completed but they do not end up having a vaginal birth, then they've done all of that laboring and then they have a cesarean anyway. So it's just a decision that the obstetrician and the patient must discuss and consider. And there's a lot in your text about this. And then your nursing responsibilities. Of course, we would prepare the mom for the procedure. There's a box in figure 19.2 on page 395. You need to know all of the things in this box. Read this thoroughly. Know this. There are paperwork and consents that have to be signed by the patient, and the nurse would initiate this and explain all of this to the patient and get the patient's signature and have it in the chart and have it ready for the physician, for the obstetrician. The nurse would obtain the lab work and complete the pre-op teaching with the patient. That is very important. Also start the ordered IV infusions and clip the abdominal hair, or sometimes they use an electric trimmer to trim all of the hair on the abdominal area. and then administer the ordered medications to decrease the gastric secretions during the surgery. Also, we need to place a Foley catheter, an indwelling catheter in the mother so that she does not urinate, and then assist women to the operative table and place a wedge under the hips, and we know why that wedge is placed there. It's to prevent the compression of the vena cava, so that the baby maintains the adequate oxygen through the placenta and through the exchange, the gas exchange, and the excretion of waste that are provided by the placenta. And also apply grounding pad for the electrocautery machine that is used, and you'll hopefully get to see this. All of this you'll hopefully get to see. And then complete the sterile prep for the abdomen. There are more steps to this in figure 19.2 on page 395, and you do need to read this and be prepared to know this. And usually it's a circulating nurse who does all of this prep in the operative suite. So procedures may be different from facility to facility, and there are policies in place within the facility. Immediate postpartum needs are very similar to the vaginal birth, except you'll just have to pay close attention to the incision and make sure there note the state of the incision and make sure there are no infections beginning with that incision. And then you'll switch your attention to, after the procedure, you will promote bonding with the mother and the baby, and also the father and the baby, and provide pain relief. You will assess the pain with the vital signs, and a woman who has had an epidural may not need pain medications in the early postpartum period because the epidural has not worn off. If medications are needed, usually an oral analgesic should be adequate for her pain. So remember to read all of that material on page 395. And now we have our practice questions. Following an amniotomy, the priority nursing intervention is to assess the color and the amount of the amniotic fluid, place dry sheets and pads under the woman, assess the fetal heart rate, assess the maternal vital signs, including the temperature. The correct answer is assess the fetal heart rate. An immediate and continuing risk is that the umbilical cord will slip down in the gush of fluid. The cord can be compressed between the fetal presenting part and the woman's pelvis. Non-reassuring fetal heart rate patterns may occur. Assessing the color and the amount of amniotic fluid, monitoring maternal temperature, and keeping the woman dry are important interventions, but not the primary intervention. Now we have question 2. The patient has been diagnosed with hydramnios. When an amniotomy is performed, the nurse is aware that the patient is at risk for which complication? Infection, placenta previa, fetal hypoxia, abruptio placentae. Abruptio placentae is the correct answer. Hydramnios will distend the uterus, and so when the uterus is distended, the abruptio placentae, the placenta may come away from the uterus implantation site because the uterus is displaced. Placenta previa is not a risk factor associated with hydramnios and or amniotomy. Remember the difference between placenta previa and abruptio placenta. Placenta previa is when the placenta is attached to an area near the cervix. So, Infection is a risk factor associated with amniotomy. However, having hydrangeas does not increase the risk factor, and fetal hypoxia may occur if a rupture placenta occurs, but is not a risk factor associated with amniotomy. Question 3. In order to monitor for one of the side effects of oxytocin, it is important for the nurse to note the patient's respiratory rate, the temperature, the intake and output, and deep tendon reflexes. So which one of those is the priority? The correct answer is intake and output. Prolonged administration may cause fluid retention. Recording intake and output identifies the fluid retention, which precedes water intoxication. Infection, respiratory depression, and alterations in deep tendon reflexes are not a side effect of oxytocin use. Thank you for viewing this recorded lecture. I hope it helps with your studying for test 1 when we come back from our break, when you come back from your break. And I look forward to seeing you in class. Thank you.